Welcome to Coffee with Kyle number 6. I'm Kyle Ridgway. Good morning. Today I wanted to get down into the weeds a little bit. I had been thinking about a concept that I had talked with some students about and discussed with some of my friends and colleagues before, and that's the problem of conflating a prognostic variable with a treatment target. And I'll give an example to kind of lay the groundwork for what I want to dive into this morning. So let's say that there's some research that exists that suggests during an acute exacerbation of COPD when someone's hospitalized, if they improve their 6-minute walk test by at least 50 meters, that person is less likely to be readmitted to the hospital or die within the next year. Okay, so we have a nice cut point that seems to stratify two potential risk groups, right? So the first one is less than 50 meters, more likely to die, more likely to be readmitted to the hospital. Second group, greater than 50 meters, less likely to be readmitted to the hospital, less likely to die. So the first thing is, obviously, this is an easy prognostic cut that helps us prognosticate someone's medical outcome based on a physical functional measure. But the problem is, it's easy to go down a slippery slope of reasoning and say, well, if we can get the group that's at risk, that's under 50 meters, let's give them more intensive therapy or more intensive interventions. If we get them above that 50 meters, they will also be less likely to come to the hospital and less likely to die. That's not exactly true. So that baseline research cut point only tells us prognosis, given the measure that we used. And we have to understand what was the intensity of therapy or intervention targeted at physical function for that group. Because now we have a whole bunch of other questions in front of us. So let's say that our hypothesis is, if we can impart an intervention that will get that less than 50 meter group above 50 meters, we think that's actually going to help their risk of readmission and decrease their chances of death over the next year. Okay, that's a fine hypothesis. Well, now we have to study it. So we take that same similar population where we did that cut point research on basically stratifying risk into two groups and setting a cut point for risk. And now we have to impart an intervention on either the high risk group or both groups. So let's say we just target the high risk group. So we find some variables that kind of at baseline predict patients who are unlikely to improve their 6-minute walk test more than 50 meters while they're hospitalized. And let's assume that these are patients with later stage COPD, patients with lower 6-minute walk tests at baseline, whatever it may be. So we get that group together and we say, okay, now we're going to impart an intervention on them. And after we impart that intervention, then we're going to see, did some of that subgroup actually improve their 6-minute walk test greater than 50 meters? And if they did, now we can look at, did the improvement in that score actually correlate with outcomes of interest like readmissions and death? Unfortunately, this is where it gets even more complicated, because now we have kind of 4 distinct scenarios that may happen. So to go back to the beginning, we have the high-risk group who in the original research did not improve their 6-minute walk test more than 50 meters and were therefore at a higher risk of both death and hospital readmission. We took that group, or what we thought was a semblance of that group, and we imparted an intervention that we hypothesized would improve 6-minute walk test and physical function, and now we're going to investigate what happens. Well, it's not just as simple as, did they improve their 6-minute walk test by more than 50 meters? We have what I think are 4 distinct possibilities. The first one is, the simple one, we gave them the intervention, they improved their 6-minute walk test more than 50 meters, and that imparted some type of prediction of less likely to have bad outcomes, less likely to be readmitted, less likely to die. Perfect. The second possibility is either for the whole group or a subgroup. We gave them the intervention did not improve their 6-minute walk test above that 50-meter threshold, and they had the same risk, the same baseline risk as the original group that we studied before of readmission and death. Perfect. Those are the 2 obvious scenarios. Well, there's 2 other scenarios that may happen here. The first one is, we improved their 6-minute walk test by greater than 50 meters, but they have the same risk of readmission and death. In other words, we got them above the original cut point threshold in the original research, but improving that didn't seem to actually improve outcomes. So we gave them an intervention that improved their 6-minute walk test during that acute exacerbation of COPD, but unfortunately, improving their 6-minute walk test in that high-risk group didn't actually improve their prognosis. Okay, the fourth possibility is that you give them the intervention, their 6-minute walk test doesn't go above that 50-meter threshold, but interestingly, their risk profile goes down. So how do we understand all this? Well, there's kind of a lot of odd causal links here, right? So the first thing we would want to drill down onto is, do we think there's a causal link or a strong enough association between physical function and these outcomes of interest? Do we actually think that there is something either physiologically, functionally, or otherwise that would suggest that not being able to prove your 6-minute walk test is either a proxy for some type of risk or actually indicative of disease status or something else that may clue us in to that this is a high-risk population? The second is when we're actually trying to intervene on this, is we've made an assumption that the intervention we're studying is actually the best intervention, not only to improve physical function, but also to affect these other outcomes of interest. So the wrench that I'm going to throw in here that we won't go into right at this moment is, you may actually have another line of inquiry that actually comes off of this original line of inquiry, which is, what is the best intervention type, intensity, and dosage for an acute exacerbation of COPD generally, but then specifically for higher versus lower risk groups, higher versus lower functional status, higher versus lower stages of COPD. In any case, back to our original example here. So, because of those characteristics, or rather because of the fact that the things are so muddied, what we have to figure out is maybe the intervention, maybe the important thing is improving the 6-minute walk test distance. Cool. As clinicians, that's an easy thing for us to take on board and say, okay, I really need to use this 50-meter mark both prognostically but also as a treatment goal, because I know in general if I get people above that 50 meters, that improves their outcomes. But secondarily, we need to also look at it as just prognostic. In other words, if I have a patient and they do not improve the 50 meters, that's not anything bad that I did, or necessarily anything bad the patient did, or anything bad the medical team did. That is just someone who has a worse prognosis. But thirdly, it is possible that the intervention that we are studying is actually beneficial to decrease risk in general, regardless of what happens with our outcome measures. In other words, if we give people the intervention that we were studying with the goal of improving them above a risk threshold of 50 meters on their 6-minute walk test, we actually decrease their overall risk regardless of what happens to their 6-minute walk test. So as you can see, analyzing even a simple piece of research or a simple prognostic cut point, such as someone with an acute exacerbation of COPD, or rather a group of patients who have COPD and have an acute exacerbation, the ones who improve more than 50 meters are less likely to be readmitted and die. The ones who are less than 50 meters are more likely to be readmitted and die. You can see that once we start to unpack that, A, there's a lot of assumptions that can be made about that cut point if we're not careful of how we're interpreting the research. And B, once we actually go to study whether or not that risk factor cut point is modifiable and important, it really opens the doors to a lot more difficult and complicated thinking. Almost like a pyramid. We started at the top, and as we kind of deepen down, there's more factors to consider in both depth and breadth. So, I think to summarize here briefly, and I maybe want to explore this more later this week, is when we have studies that either have a prognostic cut point or have prognostic variables, we cannot just assume that those prognostic variables are A, treatment targets, or that B, if we change them, we actually change people's prognosis. We have to understand that the study environment and context of what was going on so that we can compare what we are doing with patients to that prognostic study. And B, we have to be very, very careful in assuming that in prognostic studies, those variables become treatment targets that are modifiable and will change outcomes. That is a secondary line of research that we have to go into. So in any case, I'll leave you guys with that to ponder today. It was good to see you, and have a great day.